So welcome everybody to the second Venous and Lymphatic Journal Club that Tactile Medical is putting together. So this has been, our first one was a few months ago. We had pretty good response and good feedback from it. So we decided to do this again. I see we have about 20% of the participants here attended the first one and 40% are newbies. So welcome. And I hope you enjoy this. Now, we want to make it interactive. Steve, Dean, and Tom O'Donnell is part of the faculty here. And if you can please, during the course of this, or at the end, wherever you feel more comfortable, please submit your questions in the Q&A box. You can see at the bottom of the Zoom screen, if you're a newbie for Zoom, but I doubt it, you'll see a Q&A box and a chat box. And I would please ask that you put your questions in the QA box and we'll answer them as we're going along. So next slide. So these are the three papers that were presented, that were picked today. First one is going to be Dr. Tom O'Donnell talking about the correlation of disease and comorbidity with prescribed treatment among insured U.S. lymphedema patients. Then Steve Dean will talk about some cross-sectional validity and specificity on comprehensive measurement of lymphedema and lipedema of the lower extremity. And I will, if you guys are with us still, I'm going to try to put you to sleep with a basic anatomy, path, and embryology of the lymphatic system and its new developments as far as what the role of the lymphatic system in homeostasis and in disease. So at this point, I'd like Tom to unmute himself and share his screen so we can kick off with the first papers. Tom.
Thank you, Tony. It was very nice of you to have a picture of when I was at Journal Club as the introductory photograph back in the 60s. Journal Club was looked on as a time to get some sleep, particularly because we are on a every other night, every other weekend call schedule. Thanks for everybody for attending. What I'd like to do is review what's going on as across the board with contemporary treatment modalities for lymphedema and relate the type of treatment to the cause of lymphedema. As you know, you had access to this paper, which summarizes it, so you don't have to take notes and I'm sure everybody's read the paper anyway. As you know, I'm a consultant for Tactile Medical. I'm actually Chief Medical Officer, and I will discuss generic products only. We have put together some poll questions for everybody, and the first is based on insurance. Okay, I'll let you do that one. Based on insurance claims, the most common treatment overall for lymphedema is A, manual lymphatic drainage, B, simple pneumatic compression, C, massage therapy, D, compression garments, E, advanced pneumatic compression. Please put in your vote now. It's interesting. Well, the correct answer based on insurance claims is manual lymphatic drainage, as you're going to see. So let's go to the next. The next question, again, based on insurance claims, the most common treatment for phlebolymphodema directed at the lymphatic component is, again, manual lymphatic drainage, simple pneumatic compression, massage therapy, compression garments, or advanced pneumatic compression. Go ahead and put in your vote.
So, Steve, would you expect a difference in what type of therapy between overall lymphedema and phlebolymphodema? Should there be a difference? Unmute yourself, Steve.
Should there be a difference? Yeah, I think.
Would you expect a difference?
Yeah, I would expect a difference. Yeah. Especially when you're talking about a disorder with not always, but primarily a distal venous lymphatic hypertension versus possibly cancer associated where it's more proximally located. So, yeah, I would expect a difference.
Okay, can we have the results of the polls? We didn't ask Dr. Dean what he selected. And again, based on insurance claims, the most common treatment for phlebolymphedema is simple pneumatic compression therapy. Okay. So, sorry, go ahead, Steve.
Go ahead, Steve.
Yeah, I didn't find that surprising, actually, when you think about that. So
good. Well, I'm glad I'm not off the rail. This slide just portrays, which everybody's familiar with, the modalities for lymphedema treatment with complete decongestive therapy, which we all know consists of manual lymphatic drainage, compression bandaging, specific exercises, and skin care, and then below, pneumatic compression either through a simple or an advanced device. Currently, the studies on treatment of non-surgical treatment of lymphedema are focused on observational studies, usually on one modality and principally at a single center. Unfortunately, there's very little cross-comparison to other treatment modalities, and they're generally limited to a few causes of lymphedema, usually breast cancer-related lymphedema. Purposes of our study was to link the treatment modality for lymphedema with the comorbidity or cause of lymphedema, and to particularly focus on breast cancer-related lymphedema and phlebolymphedema. And here as a surrogate, we use venous ulcer for comparative purposes, and to examine whether there's any possible differences in the treatment given dependent upon the cause of lymphedema. The methods are pretty familiar with this technique using a large database. We happen to use Blue Health Intelligence with over 10 years of Blue Cross Blue Shield claims for over 180 million members. The diagnosis of non-filarial lymphedema was identified based on one inpatient or two outpatient primary or secondary lymphedema diagnosis codes, and the specific comorbidities were diagnosed by the same ICD-9 or ICD-10 codes. Finally, CPT and HCPCS codes are used to identify the treatment modalities. The outcome measures based on 12 months of follow-up after the index date were modality specific, and that's what we're going to focus on tonight, how a specific treatment modalities used within the entire lymphedema study group, and that includes more than breast cancer-related lymphedema or phlebolymphedema. The overall treatment allocation for nearly 27,000 patients with lymphedema is shown on this slide. Interesting enough, 20% received no treatment at all. The predominant form of treatment was CDT, or we labeled it conservative only, where the definition was the presence of codes for these modalities, and about 16% had codes for a simple pneumatic compression device or advanced pneumatic compression device. So the important thing is CDT predominates in this sample. When we look at all lymphedema patients and the conservative treatment modalities, which comprise 65%, you can see some form of MLD with either PT, OT, and garments, or PT, OT by itself, accounts for 73% of all patients treated. So that's the answer to the first question. Interesting enough, some combination of garments were seen in 55% of patients. Now, when we focus on pneumatic compression devices, here overall APCD predominates in 82% and about 16% with simple pneumatic compression device. Again, the patients, if you will, at risk were 4,200s for the use of PCD, i.e. 27,000 patients identified. We wanted to compare breast cancer related to phlebolymphedema, again using VLU as a surrogate regarding specific treatment modalities. And as far as claim data, the most common cause of lymphedema was breast cancer related lymphedema as opposed to phlebolymphedema. But again, you realize this is based on claims. When you compare conservative to pneumatic compression device, again, the metric being the number in the cause, total number in the treatment modality, we see that twice as many BCRL patients receive conservative therapy and half as much pneumatic compression device therapy. By contrast, patients with venous leg ulcers show the reverse. Half as much receive conservative therapy and twice as much almost receive pneumatic compression therapy. When we compare the modalities, again, breast cancer-related lymphedema to venous leg ulcers, these become quite apparent in the difference in the choice of therapy. 75% of BCRL patients receive manual lymphatic drainage and only 17% of the VLU patients. And with garments, there's about twice as many patients with breast cancer-related patients receiving garments. The lower number for VLU may be due to the elastic stocking being included in this. And this is not always picked up in a claims-based database. Most important thing for VLU is the predominant form of therapy was simple pneumatic compression therapy.
Now, Tom.
Yeah.
For a second. Now, why do you think there's such a variation?
You mean in the treatment?
Yeah.
Yeah, well, you stole my last slide.
Oh.
Yeah, I will answer that with my last slide, but that's an important point.
Yeah.
And it relates principally to who's treating it. When we compare simple pneumatic compression to advanced pneumatic compression, you can see that in red, venous etiology predominates in the simple pneumatic compression device, whereas with advanced, they're pretty equivalent, red being venous versus blue breast cancer related. So again, this theme of simple pneumatic compression devices predominating for the patients with venous etiology. So with any claims database, you rely on diagnostic coding, so you don't always identify the lymphedema patients and they have to be coded correctly. The other important proviso is these represent commercially insured patients and a group of Medicare Advantage patients, so that they may underrepresent the Medicare and Medicaid populations. And most importantly, with claims-based data analysis, the severity of the disease cannot be determined through claims, and therefore potential associations pre severity and whether a patient receives treatment remains unknown. So we would conclude from this study that, as Tony pointed out, breast cancer-related lymphedema and venous leg ulcer patients representing phlebolymphedema are treated differently specifically for lymphedema. Compared with breast cancer patients, leg ulcer patients are less likely to receive conservative approach or more likely to prescribe simple pneumatic compression devices for pneumatic compression therapies. These differences suggest that lymphatic therapy may be undervalued for the treatment of chronic venous swelling and prevention and treatment of venous leg ulcer in the general population. And then to answer Tony's very perceptive questions, one factor that may lead to the difference is who treats the patient. Breast cancer-related lymphedema is treated by breast surgeons, medical oncology, and radiotherapists with the help of lymphedema specialists in therapy, while phlebolymphedema generally are seen ultimately by vascular surgery and vascular medicine. Thank you for your attention. I'll be open to questions.
Hey, Tom, I got a question for you. I assume that with the diagnostic codes, you could not determine whether or not these were active or healed venous limb ulcers?
No, you can't. And that's actually why we are launching on a assessment of electronic health records to get the severity of the disease and granular characteristics like that.
Yeah, because I think that could play a big role in why you had such discordant differences in pump versus conservative care. Because at least at my institution, most therapists are not exactly elated to work on active venous limb ulcers, number one. I mean, I don't know about at your institution, but at active limb ulcer, they don't want to do MLD as a whole, which I don't blame them.
Well, I think the other reason, in addition to who treats it, is people are not familiar with the revised Starling physiologic equation, and they are actually, with their simple pneumatic compression device, are treating venous hypertension rather than the lymphatic component that's associated with it.
Yeah, that's a good point.
I think it's really a combination of all the above, including the fact that, like you said, they don't necessarily, many still don't see this as at least febrile lymphedema, as a lymphedema problem or lymphatic problem. Number two, the fact that many vascular specialists don't go the route of conservative therapy, include conservative therapy, whether it be MLD or compression garments or whatever. And lastly, the point that Steve made, where, if they have an active ulcer, number one, physical therapists are not going to want to necessarily do MLD on them. And number two, it's much easier to just put them in a intermittent pneumatic compression right over their Unibut or whatever they're being treated with their ulcer.
I think you're exactly right.
All right.
But when it's interesting, Tom, with this paper, and I look at it, at least to me, it just echoes what I see in my clinical practice. Everything about this paper echoes it, just to substantiate what I see. I mean, on a daily basis. I mean, if you, and it's back to those pathways that you referenced. I mean, if you have breast cancer-related lymphedema, that you're more likely to get plugged right into the physical therapy pathway, the lymphedema therapist pathway, whereas that's not typically going to happen with the venous limb ulcer.
One of the audience brought up a very important point from Doug Joseph. And he also has another one, but he questioned whether insurance, the type of insurance that a patient has, influences what therapy they'll get. And I totally agree with that. Remember, this was an assessment of patients with Blue Cross Blue Shield insurance, and it's commercial insurance. And as you'll notice, as far as PCDs, advanced pneumatic compression devices predominated. I think if you looked at the Medicare population, you wouldn't see that high proportion of advanced pneumatic compression devices. So I think
exactly.
Blue Cross Blue Shield, if you will, rules allowed a greater proportion of patients to be treated with advanced pneumatic compression devices than you might find in the general insurance population.
Yeah, there was another audience comment about that too, meaning that insurance kind of dictates a little bit of what this group of patients are being treated with.
That's right.
Oh, yeah.
Yes.
When's the last time you had a 652 approved for a venous limb ulcer? That's tough. That's really tough.
Yeah.
Well, the current restrictions are very tight on that, in that you generally have to, for some insurance, particularly Medicare and Medicaid, have to wait 6 months.
Now, do you think, there needs to be, more education in the vascular world on the use of conservative therapy for febrile lymphedema?
Yeah, I think so. But Marcus Stanborough, one of the other questions, just brought up an important point, that whether you use CDT depends upon the availability of therapists. And they may not be available in some more remote geographic locales. And also, as you brought up earlier, the vascular specialists may have not worked that protocol or flow of patients.
In the paper, you said they looked for treatment within a 2-year period?
No, there's 1 year before to get pre-index date. That's when they started treatment to 1 year afterwards.
Okay.
So that implies one of the other drawbacks of claims data and why we're going to electronic health records is it doesn't provide you, if you will, the sequence of treatment.
Correct.
You go directly to pneumatic compression device, or do they go through CDT, as most of the breast cancer patients would?
Yeah. Yeah, because a lot of those VLU patients, maybe, not a lot, but maybe a number of them had MLD 2 years prior.
Could have.
Yeah.
We'll know that when we do the AHR. But I would suggest a lot of patients venous patients go directly to pneumatic compression device, as the data shows.
Yeah.
Doug Joseph again asked a question: were any patients treated surgically? We don't know. We didn't look at that in this data analysis, but we will be in our electronic health record analysis.
All right. I think that's about it for questions. Any other thoughts, Steve? Or any closing remarks, Tom?
No, just again that I like I said, I just didn't find these results surprising. It was I think illustrative just to see it in print, but that is the typical pathway for both prescribing both advanced and simple pneumatic devices, compression devices.
Any follow-up on this, Tom, that you're planning on doing? You said,
as I said, yeah, we're going to be doing some electronic health record analysis. We're meeting on that, so stay tuned to this billboard.
Okay.
I guess my last question would be, I'd put it out to Tony or Tom, is do you think there is any benefit to prescribing an advanced pneumatic pump in the setting of chronic venous insufficiency with the limb ulcer versus a simple? Do you think that really matters?
Well, I can answer that directly from the study that was published using the same data by Stan Roxon, and the first author was Lerman. It showed two things: a very significant decrease in medical resource utilization with a combination of an advanced pneumatic compression device and conservative therapy versus conservative therapy alone. And it also showed superiority of the advanced pneumatic compression device, which happened to be a FlexiTouch, over simple pneumatic compression device as far as costs and medical resource utilization. So the answer to that is emphatically yes, at least if you're interested in cost and medical resource utilization. And most importantly, as you know, although not directly comparing to a simple device, Dr. Tom Maldonado's study presented recently showed that over a year, the episodes of cellulitis were markedly reduced in patients treated with advanced pneumatic compression device.
All right. Why don't we move on, Steve, if you want to share your screen?
Yeah, absolutely.
Don't seem so excited.
Oh yeah, I'm actually really excited about this. Yep. More than you know. All right. Yeah, so here we go. My riveting topic here is cross-sectional validity and specificity of comprehensive measurement in lymphedema and lipedema of the lower extremity. And this was a comparison of 5 outcomes instruments. This was a study out of Switzerland by Angst and colleagues. All right, for disclosure, same as Dr. O'Donnell's. So here's our poll question number 1. Which of the following instruments is specifically designed for psychiatric symptoms, which both plague both the lymphedema and lipedema patients? And I will tell you that if I wouldn't have reviewed this paper, I would have no idea on the answer to this question. So I'm just curious how the audience did. So Tony, waiting for just that to, yeah, here we go. Okay. And let's see what we got here. Oh, yeah. So see, you're just like me. I would have got that wrong. The correct answer is actually the SCL90R assay. So we'll come back and talk about that briefly. So that was a good question. It's worth going over. It's strictly a psychiatric scale, the SCLR90R. So here's the background. Literature on the validity of outcome measurements in lower extremity lymphedema and lipedema is actually quite sparse. And in fact, there are no published validity data on outcome assessments for lipedema. So this study aimed to examine the validity of 5 instruments in both of these conditions. So as far as methods, here's the inclusion criteria. These were pretty standard. It was an adult population. They had a confirmed diagnosis of stage 2 to 3 lymphedema, stage 1, 2, or 3 lipedema, or combined lipolymphedema, denoting what they said was advanced lipedema with secondary lymphedema. But I digress. And like we've noticed in forums such as these many times, lymphedema can complicate any stage of lipedema. It does not necessarily have to be advanced. Now, I did find the exclusion criteria somewhat interesting, specifically the fact that they excluded patients that had chronic venous insufficiency or phlebolymphedema. They also excluded patients with cardiac, renal, or liver failure, patients with super obesity with a BMI exceeding 50, and finally, any patient that had mixed edema of unknown origin or the classification of their exact limb swelling was unclear. But again, no phlebolymphedema in this patient population. So here are the methods, and here are the 5 assays or instruments that were referenced. The short form 36, the Freeburg QOL assessment for lymphatic disorders, short version, you can see the abbreviation there. The knee-specific outcome survey activities of daily living scale, that's the COS-ADL. And here is our SCR or symptom checklist 90 revised SCL90R scale. And finally, the 6-minute walking test. And for you statisticians out there, you got to love this. Construct convergent and divergent validity was quantified by bivariate correlations and multivariate factor analysis. And of course, discriminant validity by standardized mean differences.
That's actually a major criticism of this paper. This is not what they should have done, but I won't get into the details.
Okay, well, I'll let you talk about that later. Yeah, good point. That was brought up. So here's some of the data from Table 1, looking at various socio-demographic and disease-relevant data or variables and comparing them between lymphedema and lipedema. And of these variables, there were only 3 that were statistically significantly different between the 2 cohorts. We can see here from a female gender standpoint, lymphedema was 71%, lipedema by definition was 100% of the patients. So there was one of the variables that differed. The BMI, you can see here that the lymphedema group fulfilled the diagnosis of being overweight with a BMI of 28, but the lipedema patients were bigger with a BMI of 35, fulfilling the definition of obesity. And finally, from an age standpoint, the lymphedema patients were older at 56, they were younger in the lipedema group at 47. So not surprising, lipedema population was obese. So here's poll question number 2. Which condition resulted in consistently worse measures on all scales? Was it lymphedema or lipedema? Outstanding. We can see that the majority of you got this correct. That is lipedema was most likely to be associated with worse measures on all of the scales. So that will lead into a nice segue into Table 2, looking at score data and comparison of all these variables within the setting of the 5 previously mentioned scales. And let's individually and explicitly go through every one of these. And that is a joke. Actually, I'm going to save you a lot of time and just tell you that the outcome of lymphedema was consistently better on all scales when compared to lipedema. Take home point. And also continuing a little bit more granular data on results. Health was consistently better in lymphedema than in lipedema. And the highest construct convergence was found for physical health between the SF36 and the KOS. That was the knee-related scale, ADL scale. And just within this theme, when you talk about health, of course, you have to consider pain in the context of health. And just in the interest of talking about pain in the setting of lymphedema and lipedema, I've got two just brief references to other studies I wanted to point out and just bring up the topic of pain in the setting of lymphedema and lipedema, because that was, at least from a clinical standpoint, something I found interesting in this paper. And here's a paper from, you can see 2018 from Sheila Ridner and Associates. And in their cohort, when they looked at symptoms in the setting of lower extremity lymphedema, they noticed that 55% of their patients had limb pain. And first of all, I think that's interesting. That definitely caught my eye when I looked at this paper. I just want to talk about it in the context of this paper, of course, is Tony and Tom, when you see patients with lymphedema, do they typically complain of a lot of pain?
Not really.
No, that's supposed to be one of the characteristics of lymphedema, that is painless swelling. Exactly
right. So I thought that was interesting in the sense that this is out here, and I just, as a whole, I don't find that either. Yes, and I've heard Stan Roxon talk about this a lot in the sense that, well, it's definitely underappreciated, and I guess that could be, but if they do have pain, I think it's very mild. And you contrast that with the good Dr. Herbst paper that Herbst, she's going to be upset at me for saying that. When in her population of lipedema patients, 90% of these patients had daily pain. So again, just showing you the contrast in the pain between lymphedema and lipedema. Now back to our paper and end up on the discussion. From a strength standpoint, this was the first paper to examine and compare a comprehensive set. That's 5 sets of generic and condition-specific outcome measurement scales, and to analyze their cross-sectional validity within specific construct dimensions in both lymphedema and lipedema. And it was large enough to ensure that minimally clinically important differences reached statistical significance and to fulfill the requirements for valid factor analysis. The limitations, I think Tony's already brought that up. It was a cross-sectional study, which excludes the dimensions of outcome changes over time. And here are the 5 takeaway points, really, from the article. The outcome of lymphedema, again, was consistently better on all scales when compared to lipedema. The generic SF36 scale displayed high construct convergence with the condition-specific tools and a good ability to differentiate between lymphedema and lipedema. I think that's important. And the ability
to define construct convergence for those of us who...
I think it's just how the symptoms line up. If you have it on a scatter graph, there's correlation between the variables, basically.
Okay.
The ability to specify between lymphedema and lipedema was greatest in pain. And it's a continued topic here, which is why I addressed it. The gold standard criterion for differentiating lymphedema from lipedema is the presence or absence of pain. And the knee outcome study, ADL, was the most powerful instrument for differentiating lymphedema from lipedema, especially in reference to function. And so our final slide here, all 5 instruments have specific strengths and can be implemented according to the scope and aim of the outcome examination. And if you are a researcher, a minimum measurement set should comprise the following. That is SF36 bodily pain, vitality, the Freiburg quality of life assessment, LK, which is lymphedema. You can see here physical complaints, social life, emotional well-being, health state, the D outcome study, ADL, symptoms, function, and finally the SEL or symptom checklist, 90-hour interpersonal sensitivity. So, and how I just sum up this paper, again, if you're a lymphedema researcher, I suspect this is a very important paper to you that give you data that's not out there. From a clinician standpoint, which is how I look at it, I think it just validates what I see in my practice, and that is that lipedema patients are significantly more disabled from both a mental and physical standpoint than the lymphedema patient. And again, this continuing theme of which Tom had mentioned here, lymphedema is typically a relatively painless condition versus lipedema is typically painful. And again, I would reference even Karen Herbst's data where 90% of those patients have pain. So, Tony, what was the criticism you had as far as the construct convergence?
I was just kidding.
Okay.
Yeah, I think when you see,
you have to love a paper like this, doing all the research that you do, I would think.
Well, from a clinical perspective, I mean, do you use any of these quality life measures?
Not from a clinical standpoint, no. I mean, it's in your history, et cetera, but I don't document anything like this on my.
And when you compare the two groups, was it mostly pain that was in all these quality of life?
It's centered around pain, but it was as you can imagine. I mean, all the typical symptoms you look at, but pain always showed up in this. But I mean, again, you got to look at even the mental, the psychiatric toll as well was assessed in all these.
Okay.
I find it interesting that they didn't mention LymphQual, which is a disease-specific QOL, and they use SF36, which is a generic QOL. Only a Swiss patient could participate because it'd take you about 2 hours to fill out all these forms for the various assessments.
Yeah. So again, it's back to, I think it underscores important. It's an interesting paper, but it's really relevant for research. It's not relevant for a clinical practice. I don't think.
So when you see a patient with pain and the patient has lymphedema, what do you think of?
That's an interesting question. I would wonder if there is some underlying inflammatory component, something that's undiagnosed, maybe a Charcot's foot, some type of tendinitis that's associated with it.
Or infection.
What's that?
Or infection.
Yeah, infection, but I would think that's pretty obvious just based on the condition of the skin. Yeah, of course I would think of infection, but yeah, that should be an obvious one. I will say, though, from a clinical standpoint, I am impressed with some of the stage 3 elephantiasis patients. A lot of those patients do have significant pain sometimes. I think there's a thought it may cause a compressive neuropathy,
but that's usually a small group of patients in clinical practice.
Yeah, for my practice, yeah. It depends on where you practice. I've got a lot of.
Since you see a goodly number of patients with lipedema, can you comment, Steve, about the characteristics that beside pain that you use to make the diagnosis?
I would just go back to the cardinal features. It's a symmetrical fatty limb swelling that is diet resistant. It's painful. And it's associated with easy bruising as well as orthostatic edema. And I think that would be a good 4 ways I would look at it.
And how do you think the lack of inclusion of phlebolymphodema biased the lymphedema assessment?
How did that bias it? Boy, that's a good question.
First of all, I would say obesity would be higher in the phlebolymphodema set, at least from your data.
Well, that's okay. So we couldn't argue with that. Yeah, exactly right. I mean, it was 40. Our BMI was 46 in our paper. So yeah, that's one way I would have biased it. So maybe you would have had a little bit more pain with CVI if you did have phlebolymphodema. Yeah.
Why is it that the phlebolymphodema patients tend to be more overweight compared to your typical lymphedema patient? Any thoughts?
No, I mean, I guess I would even say between that, it depends on if you're talking primary or secondary lymphedema, because as I'm sure you noted in your paper, Tony, that if you follow these primary lymphedema patients out a long period of time, they're obese. I mean, they most of them are. It's rare to follow a primary lymphedema into their 40s that's not obese, and they almost all are.
Yeah, but for this paper, it was, what was it? The BMI was 20.
Oh, you mean as far as in the lymphedema? Yeah, it was 28, I think. It was it was a lightweight.
Whereas with phlebolymphodema, like Tom mentioned, they tend to be a higher BMI.
Yeah.
It's what's the chicken and what's the egg? Does the discomfort from the lower extremity of phlebolymphodema limit your activity so you can't burn calories, or is it the reverse?
Plus, maybe it's the obese patient that has some venous disease, but their obesity is contributing to their phlebial lymphedema.
Right.
Yeah.
Any questions?
Yeah. Liposuction.
Any comments on experience with liposuction for lipedema?
Comments on yes, it's the most effective treatment for lipedema or lipedema. The problem is it's just so hard to get reimbursed. Even if you find reimbursement, it's equally hard to find a plastic surgeon that even knows about lipedema and knows how to do the correct procedure. It's just a tough disorder to treat.
Yeah.
But with any liposuction, either lymphedema or lipedema, the patient is wedded to continued use of either MLD or usually pneumatic compression to maintain the reduction.
Yeah.
Any comments on Steve, on patients with lipedema and pain, and as far as using compression as far as improving their pain or symptom relief or anything here?
That's a tough one. First of all, the chance that most lipedema patients are going to tolerate high compression, that is a 30-40 weight garment, is very, very slim, or low, I should say. It's just as a whole, the cutaneous hypersensitivity obviates high compression. They just don't tolerate it, just like they don't tolerate a conventional pump. That's where the FlexiTouch is superior, I think, in treating lipedema from a pump standpoint because of the light touch. So back to answer your question, I think there is a subset that does benefit from light compression in reducing their pain. But then again, I have a subset that they don't want any compression. They just can't tolerate anything. So it's variable. The 15-20, I think, is pretty standard for most of my patients.
All right. It's 8:45. So why don't we, I'll share my screen and present the next paper, which is really not a paper typically for Journal Club, but it made me do some reading and learn some stuff that I think is interesting. Let's move this out of the way. So, lymphatic vasculature in the 21st century. So, probably the education of the lymphatic system and disease in medical school is, venous disease, it's about an hour. For lymphatic, it's probably 2 minutes. So this is way more than any of us got in medical school. Disclosures, consultant advisory board on the Tactile Medical. And we're going to basically cover a little bit about anatomy, embryology, make a few points on the historical views of the lymphatic system when it comes to immune surveillance as well as disease conditions and disorders, and then touch a little bit on recent discoveries of the role of the lymphatic system overall. And starting off with anatomy, when you look at the beginning of the lymphatic system, way down in the cell level, you have the lymphatic capillaries, or the initial lymphatics they call, which are basically made up of a single layer of lymphatic endothelial cells. And these lymphatic endothelial cells are loosely connected to each other with really absent basement membrane. And really those two things, when it comes to the structure and the architecture of the initial lymphatics, allows them to be very highly permeable, which helps with uptake of interstitial fluid, leukocytes, and macromolecules from the interstitial space. From there, from the initial lymphatics, lymphatic fluid, it's advanced through the collecting lymphatics. Here, the endothelial cells of the lymphatic system have a little bit tighter junctions, zipper-like junctions, and they're covered with some smooth muscle cells, which again, these smooth muscle cells help from a functional perspective through contractility to propel the lymphatic fluid, similar to like in the venous system where you have the calf muscle pump. helping with the propelling of venous blood through the venous system. And then, similar to the venous system, you have unidirectional valves in these collecting lymphatics, which allows fluid to go antegrade and prevent retrograde or reflux. So here's our first poll question. So from the collecting system from the lymphatics drains the thoracic duct into where? The heart, the left lymphatic duct, the subclavian jugular vein, or vena cava. So yes, everybody got that right. Hold on a sec. Sorry for the background music.
I thought he was cheering for the correct answer.
So obviously, correct answer is the subclavian jugular vein. As small as that dog is, it's very annoying. So from there, you have the lymph nodes next, which acts as a filtration. So this dog, I never wanted this dog. But the only good thing about it is if somebody comes up to my door, it goes crazy. So sorry about that. I think we took him out of his misery. Sorry for any dog lovers out there. But so lymph nodes act as a filtration system to allow initiation of the immune response. And then you also have the afferent and efferent collecting lymphatics. So you have your afferent draining through the lymph nodes, and then exiting the lymph nodes through the efferent collecting lymphatics. And from there, you go through the thoracic and the right lymphatic duct that drain into the subclavian jugular veins. Now, from a development perspective and embryology, and here, for those who don't know, the relationship of the lymphatic and the venous system is so tight is because actually lymphatic endothelial cells arise from the cardinal vein. So these are progenitor cells that lead to the development of lymphatic endothelial cells. And other sources of progenitor cells for the lymphatic system include the heart, the skin, and the mesentery. Now, vascular endothelial growth factor C plays a significant role in lymphangenesis. And as you can see in the diagram there, you have the migration of the lymphatic endothelial cells and the formation of lumen, and then subsequently the smooth muscle cells develop around the collecting lymphatics, and then development of the valves that allow the unidirectional flow. Now, most of the endothelial cells, most of the progenitor cells develop into endothelial cells, but you have a subpopulation that remains in the cardinal vein and help form the lymphovenous valve that connects the lymphatic system to the jugular subclavian vein junction. So historically, when you look at the lymphatic system, obviously we know that the major thing everybody knows is the lymphatic malfunction leads to development of lymphedema. We also know that the lymphatic vessels play a significant role in tumor metastases and provide a route for metastases. And finally, the role of the lymphatic system in immune response and inflammatory response. So when it comes to lymphedema, primary and secondary, with primary lymphedema being either underdevelopment of lymphatics or abnormal dilated lymphatics, leading to insufficiency of lymphatic transport. And there's numerous genetic defects that have been identified that interfere or have a problem with developmental stages of the lymphatic system, whether it's the valves or the lumen of the lymphatic system, and you end up with primary lymphedema. This is just a list of some of the most common genetic abnormalities leading to lymphatic disorders. And when it comes to the second question, we talk about lymphatic function includes interstitial fluid reabsorption, immune system, malignancy, none of the above, or all of the above. So obviously, we've covered pretty much this. And lymphatic system historically, these are the three major things that we know is involved with. But I'm going to touch in the next few slides after these, but I'm going to touch a few other things that have been recently developed. So with the immune system, we talked about lymphedema, but on the immune side, you can see here in this diagram how through the afferent lymphatics, you have bacteria that get passed through the lymph nodes, and the lymph nodes act as a filter for pathogens. They also contain activated antigen presenting cells. And finally, they act as a signal to attract neutrophils when there is an infectious process going on, and contain that infectious agent and prevent it from getting into the systemic system and leading to sepsis. In tumor metastases, the thought has always been that lymphatics have a critical role in the metastases, but more recent evidence actually has shown that distal metastases frequently arises without passing through lymph nodes and actually spread directly from the primary tumor to a distal site. And that lymph nodes may have some type of protective effect in containing metastases to the lymph nodes rather than getting distal metastases. So for example, colorectal cancer metastases, 65% of lymphometastases are completely unrelated to distal metastases. So the thought is, again, that the lymph nodes may be a barrier for dissemination of tumor rather than a route to lead to tumor metastases. And when you have a failure of containment within the lymphatic lymph nodes, that's when you get into trouble, whether it's either bacteria or tumor cells. And here you can see that if containment fails, you have a systemic release of these bacteria, leading to sepsis or to distal metastasis, or DIC, when it comes to lack of containing F3 expression antigen presenting cells, which is related to thrombotic complications in DIC. So some recent discoveries that I'm going to touch about, again, just briefly, because in the paper it has extensive data when it comes to animal models and human studies that have been shown the link between lymphatic abnormalities to obesity. So in mouse models, it's shown that when you have leaking lymphatics, it leads to excess adipose tissue. And now, surprisingly, we see a significant deposition of adipose tissue even in lymphedema patients in the lower extremities. But overall, there's a thought that obesity has some type of significant correlation with abnormality in the lymphatic system. Similarly, there's some data showing correlation with bowel disorders, including inflammatory disease with Crohn's disease. And then this whole other list with anything from glaucoma because of resistance and outflow of aqueous humor, atherosclerosis with coronary disease, and PAD and acute MI. So in both in PAD, the vasa vasorum has lymphatic network, and it's felt that lymphatic network may have a role in limiting the cholesterol accumulation and plaque inflammation. In the heart, helping with fluid hemodynamics after an acute MI, and helping with recovery, as well as with overall coronary disease, where lymphatic vessel growth and function could have some role in development of plaque within the coronary vessels, and that manipulation of that lymphatic vessel growth may have some therapeutic approaches in combating cardiovascular disease. And then finally, there's been a bunch of neurologic disorders that have looked at, including Alzheimer's, Parkinson's, and MS. So kind of summary, there's many functional roles other than the typical historical view of the lymphatic system with interstitial fluid buildup, and more recently with the revision of the Starling law showing that any edema is really a result of lymphatic failure. But it goes beyond that, where we're talking about multiple disease processes where the lymphatic system may have a role. And alterations, it's obvious from these early studies that alterations in lymphatic vasculature may be responsible for several pathologic conditions. And a better and deeper understanding as we go forward of genetics and signal pathways may help in managing these diseases, and that therapies that support lymphangenesis may further allow new therapies to overcome these conditions. So if everybody's still awake, open for questions.
Tony, the only thing I have to say is I'm just surprised you didn't interject the word glymphatics in there. That's my new buzzword after reading that.
You like
paper.
that?
Lymphatics, yeah.
So
Excellent summary of a complex topic.
yeah, I left you guys. I left you guys speechless.
No, it's good illustrations.
So do you think is there a role for the FlexiTouch, the head and neck piece to reduce these neurodegenerative diseases? I think that's a provocative question.
I mean, that's a provocative question. There is some thought, I think, and I believe in Harvard, is it, or somewhere, that they're looking into, the neuro division there is looking into how improving lymphatic drainage in the brain may help with reducing protein deposits in some of these conditions with Parkinson's and Alzheimer's. But I really don't know too much of what they've been doing. I know some peripheral things that I've heard. Tom, do you have any insight on it?
One of those.
Well, I think for the moment, given everything you're right on, the fact that people never thought there were lymphatics in the brain or in the glia, and now they've been discovered, and with that, as you outline, promoting drainage, fluid drainage, may impact upon the plaque development thought to be associated with neurodegenerative diseases like Alzheimer's.
Yeah, I mean, that thought has been around even with the venous system. I mean, with Venous, where there was a thought there was a jugular venous outflow problem, and there was a thought a few years back that stenting the jugular vein and improving the venous outflow will help decompress the hypertension in the brain because of that. But obviously that didn't pan out. I'm not sure. Maybe it is, a lymphatic problem. We really don't know yet. But there is some animal studies that have shown, ligating the lymphatics in the dura of the brain, increasing the deposition of amyloid in the brain.
Any questions?
COVID and the lymphatic system. I was actually thinking about that when COVID happened, because I was seeing a tremendous number of patients with lower extremity new onset swelling. And at first, we were thinking, people are just staying home. They're not as mobile, sedentary lifestyle, and maybe that was the reason. But we know very well with COVID that there was an attack of endothelial cells in the venous side and the arterial side, and thrombosis, leading to thrombosis. So I was entertaining the thought. Actually, I spoke to a few of the people from Tactile. Could it be that in COVID there was an attack of the lymphatic endothelial cell causing dysfunction, and that's why people were getting so much swelling? I don't know. What do you think? Or am I just full of?
Maybe a lot of IV fluids when they're in the hospital. Who knows?
No, this is for outpatients. I was seeing patients, telemedicine patients, like a significant number of new onset swelling.
How many of them had duplex ultrasound that was negative so that you couldn't ascribe it to the venous side?
Most of them, when all of them, we would bring them back and just for to make sure they didn't have a DVT. But
that's really curious. I don't see these patients. So, Medications. Did they have dorsal foot swelling, or was it pitting? It's just very curious to hear this.
There was patients, combination, both with dorsal foot, some of them not. Again, it may be just related to them not being mobile.
Yeah,
And were they really sick and immobile, or?
No. These were some of them were young patients.
There's a research project.
Yeah. It wouldn't be far-fetched. We know that the coronavirus attacks endothelial cells. That's one of the major issues.
There's a statement on the, I think it's the MLN site because we've had a lot of phone calls coming in about that very question. I have lymphedema, I need to be worried about COVID? And they specifically addressed that and said, unless you had, which makes sense, unless you had some type of primary lymphedema that involved your pulmonary system or one of the affected organs, it really shouldn't predispose you to having COVID.
Can we improve the function of the lymphatic vessels through stimulation of its smooth musculature?
What do you think, Steve?
I would think so. Physiologically, that's what's happening. So if you're doing something to stimulate the smooth muscles around the pre-collectors or collectors, yeah, I would think so.
What about drugs that you take that may affect the smooth muscle, i.e. decrease the activity? Are they associated with edema?
Well, yeah. Indirect. Calcium channel blocker is a great example because you're avoiding arterial reflex, which is initially neurological reflex. So, yeah, affecting the smooth muscle cells. So, yeah.
I just submitted a paper in the American Journal of Surgery about appendicitis perforating earlier with COVID. Lymphatic obstruction may explain this. That was just a comment. What treatments do you recommend for lipedema and lymphedema in super obese patients over 500 pounds? Steve, you're the expert on this.
No, I would just see you have to have gastric bypass if you can get somebody to do it. I think that's going to help out more than anything. And what else can you do? I feel so bad for those patients because you see them and they're 500 pounds and without a gastric bypass, it's just a downhill spiral.
Certainly on the venous side, there's been studies pre and post bariatric surgery that have shown that the elevated venous pressure pre-bariatric surgery is reduced by bariatric surgery.
Yeah.
All right. Well, we are not too many more questions. So we're 6 minutes past the hour. Can we put up the couple of slides at the end here as we're closing off? So I want to thank everybody for attending our journal club. This was actually Dr. O'Donnell's idea. I think so far we've had a great success. I want to thank Tactile for putting it together and providing this educational opportunity for everybody. And then I just want to touch a couple of upcoming events that are scheduled. Next slide. We don't have them? Okay. Well, any last comments, Steve or Tom?
No, I just like the whole glymphatics phrase. That's my buzzword for the evening, glymphatics. Yeah.
Well, thank you, Tony, for running and moderating it. Moved along very nicely. And I think you were, in all deference to Steve, assigned the most difficult topic to present and summarize. So thank you for your efforts.
Yeah.
I know your dog enjoyed it.
Yeah, sorry about that. All right, everybody. Have a good night, and thank you very much.
Thank you, everybody, for your attention.